10 years old, so it's not light on my face. So I'm talking about genicular artery embolization for knee osteoarthritis, no disclosures. So as we all know, osteoarthritis of the knee, it's very common. It's the most common arthritis that presents to your rooms. It affects about 500 million people in the world. It's very prevalent in the over 65 age group, males and females, so a disease of no gender. Has a lifetime risk of about 45%. Obviously increases if you're obese. And the key point here is symptomatic pain will lead to disability. And so the key is to control pain early, and this may delay surgery. So the pathophysiology of osteoarthritis in general traditionally was thought to be a wear and tear process, a mechanical process, which is only partly true. So a paper that was published in 2002 in a rheumatology journal actually proposed that it's actually a chronic hypervascular inflammatory process. And it goes through this cycle of there is an incident event that causes inflammation, usually starts off with synovial inflammation, and what happens with that synovium is it secretes inflammatory mediators into the synovial fluid, and then that eventually reaches the cartilage. If this continues, then you get edema on the cartilage, get some fissuring, it goes into the bone, and then that's where, if that continues, you get mechanical forces that change because of new bone growth, new vessel growth, and that keeps continuing to what we see radiologically, which subsequently leads to pain. And just looking on here, these inflammatory mediators, the one that we're very interested in is this VEGF, so this vascular endothelial growth factor. This is involved with angiogenesis, so new abnormal vessel formation, and with that you also get new nerve formation. And it's this new nerve formation that is the source of pain in osteoarthritis. So we can grade this radiologically on conventional x-rays with the Kellgren-Lawrence grading, 0 being normal, 4 being severe. This is an example of it. So normal knee on the left, no radiological features of osteoarthritis, and then grade 4 on the right, where there is bone-on-bone joint space narrowing. This whiteness here on the end of the joint in this medial compartment is subchondral sclerosis. It probably doesn't project very well, but you're getting this very faint lucency here. This is subchondral cystic change. This happens when there's degradation of that cartilage, fissuring, and then leaking of that synovial fluid into that juxtaticular bone, and also getting osteophyte, obvious osteophyte formation. 1, 2, and 3, somewhere in between. This is just an example of someone who's had a previous injury, had a knee replacement eventually, and now has a Kellgren-Lawrence for bone-on-bone joint space narrowing and all those other features. So, what is the management? I stole this from the College of GPs, and their suggestion, which is what we probably practice all the time, is non-surgical management first, starting off with education, weight loss, and exercise. If this doesn't work, then you're referring them on to a multidisciplinary team, physios, other people to help with aids, behavioral therapy, and also the introduction of oral analgesia, starting with NSAIDs. If they fail that, then you're obviously thinking, I got to refer this patient on to a surgeon, so you make a referral. Wait lists are quite long, so you have to do something else to control the pain, so you're giving more pharmacological management. And that usually results in intra-articular knee injections with corticosteroids. You can inject them with other things like PRPs, but also off-label use of duloxetine. And then eventually they'll end up with a knee replacement. So the European Society of Osteoporosis, Osteoarthritis, and MSK diseases has a very similar flowchart, but a bit more aggressive, and I think also non-evidence supported. Starting off with education, weight loss, and exercise, they go into the oral drugs quite early in conjunction with the physio exercise and aids. but they, strangely enough, they recommend the glucosamine, the chondroitin, which the evidence is it's been inconsistent, but also the use of PRN paracetamol, along with topical NSAIDs. If this fails, they go on to more oral medications, so NSAIDs, but also escalating that pharmacological management with intra-articular drug injections. Again, if this fails, they escalate it to duloxetine, but they recommend opioids for short-term use. Then they'll end up with surgery, however it's contraindicated. The only thing they can do is throw more opioids at it. So, is this effective management? So, a systematic review meta-analysis published in the MJA in 2022 looked exactly at this. 36 placebo-controlled trials for hip and knee osteoarthritis and dose-effect relationship. They included all drug regimens that included opioids, whether it was just a single drug of opioids or all the combinations that were mentioned before. And they compared it to the placebos, and they concluded that opioids actually don't work very well in knee osteoarthritis. However, you increase all the adverse risks. We know the minor ones, but just to remind you, the major ones are respiratory depression, dependence, overdose, and death. So, what are the societal costs? Monash University Epidemiology Department in 2018 looked at opioid prescriptions for osteoarthritis pain, not specific to any joint, but just overall. And in 2015, 2016, they found that there was 1.1 million opioid prescriptions. They projected that in 2030-31, this is going to triple. The cost of the healthcare at the time in 2015 was $25 million, and this will also triple to about 70 million. And they concluded that we need more effective pain management strategies to reduce the reliance on opioid use. So that brings me to genicular artery embolization. So it's an emerging technique for knee osteoarthritis, treatment of pain. The idea is, the theme of tonight is going through vessels, so endovascular management and injecting these embolics. So same sort of thing, we go through an artery, either through the wrist or the groin, sometimes in the lower leg, and we go into those vessels that supply the knee, so the genicular arteries. There's multiple of them, they start about 6 to 8 of them, but we target the ones that are local to the patient's pain, so we break them up into compartments, medial, lateral, and anterior compartment, and it's blocking off these abnormal vessels, these small ones, until we get this prune tree appearance. So this was first performed by Dr. Kudo in Tokyo, Japan. He first did it for bleeding following a knee replacement, and then thought he'd try it on a very small subset of patients with knee osteoarthritis, knowing that it's a chronic inflammatory process. And he assessed it with what we call the WOMAC score and the visual panoramic scale. And clinical success was considered 50% reduction of that score. So, just a schematic of what we saw previously. This is the genicular artery supplying the synovium that is chronically inflamed. What we're doing is we're blocking off those this inflammatory cascade where it starts. So, no inflammatory mediators get secreted to the synovial fluid. Subsequently, this breaks the cycle. So, an example of the WOMAC scoring sheet, it assesses multiple facets, ADLs, functional mobility, gait, and general health and quality of life. They put into 3 categories with its own score, so pain out of 20, stiffness out of 8, and physical function. The sum of all these scales add up to 96. Higher score relates to worse pain, stiffness, and limitations. So an example of a visual analog scale or VAS scoring, we use this mainly to follow up patients because you don't want them to be answering so many questions all the time. It's very easy for them to just put a cross where their pain is at that point in time. Dr. Kuno's study selected patients between 40 and 80 with mild to moderate osteoarthritis, so Kelvin Lawrence 1, 2, and 3. They had to have clearly localized pain that they could get a finger and point to, which localizes the compartment, as opposed to generalized pain. And they have to have trialed more than 3 months of conservative management. And so the first study he performed was a very small subsegmentation of 14 patients, and surprisingly found the pain score in the WOMAC category out of 20, baseline was 12 and had dropped to below 2 at 4 months. He repeated this in 2017 with 72 patients and found a very similar result. So baseline of 12 coming down to about 2.5, 3 at 24 months. So he followed them for 2 years. Studies have now being performed around the world, UK, US, Australia here as well, all with very similar findings and still ongoing. So one of the most recently published papers in UCLA by Padia followed patients for 2 years, and they did a prospective single-arm study, same demographics, 40 to 80. They actually took moderate to severe knee osteoarthritis cases, and same sort of thing, had to fail more than 3 months of conservative management. They followed up for 2 years at varying time intervals, and they excluded patients with very little pain. They had to have not had PAD or be actively smoking, and no previous surgery. They found that 12 months out of those 40 patients, about 2/3 of them had a clinical success, reducing their pain score by more than 50%. And then at 24 months, 2 were lost to follow-up, so 25 patients out of those 25 that had success at 12 months, 18 of them still had sustained clinical success. So just a schematic. So the ones that were successful at 12 months from their baseline had a pain reduction of about 80% in their WOMAC scoring. So just another schematic showing the timeline of the pain following an embolization procedure. Obviously the one in red is the clinical failures, which they stopped following at 12 months. So the blue line here showing clinical success. You get maximum relief at about 3 months, or just over 3 months. The pain will slowly creep up again, and then it tends to plateau at about that 12 months to 24 months. So the way we do it, as mentioned, we go through an artery in the groin, we can use the lower leg, we use very small, fine catheters, X-rays and contrast dye, and same sort of thing. We get into the branches supplying either the medial, lateral, or anterior compartment, so that can be 1, 2, or 3 vessels, and we inject our contrast. And what we're looking for, you can see that there's a marker here that this operator put on, where the patient has actually placed one finger where their pain is, which corresponds to this area in this medial compartment where this cloud-like appearance, what we call tumoral blush. And we embolize using these tiny little beads, as mentioned before, to the point where we don't see that tumoral blush anymore. So we call it a prune tree appearance. We maintain the main normal vessels and remove the abnormal neovascularity. Just another one, so less impressive than the last, but you're getting this tumoral blush here, and again, tumoral blush, and we prune tree appearance. So these are the embospheres. We tend to use the smaller ones. These are large ones that we will use for bleeding post-knee replacements, and we hyper-dilute it. So you see that it's 2 mils, we remove some of that, mix it, and then we just take that very tiny percentage, and it only requires maybe less than 1% of what's there. Complications, the standard complications with contrast and sticking needles into arteries, so bleeding. But specific to GAE is the ones we worry about is this non-target embolization. The particle's going to the wrong area, and they describe skin ulcerations, skin changes. There's been a few cases of bone infarct, which hasn't required any further management, and very rarely a neuropathy and anastomosis supplying a nerve. Nothing's required any drastic surgical management. No toes removed. Plastics haven't had to do any skin grafts, that's been reported. And in terms of follow-up, the patient will have pain after the procedure, so that's the ischemic pain. And it's especially if we use very, very small particles, so below the ones that I've shown you, and also if we over-embolize. We give the patient a pain diary to take with them to follow on what their course is over varying time. I tend to go 1 day, 1 week follow-ups, and then every 3 months after that for the first 12 months. And they should always continue their multidisciplinary approach. So, where does GAE fit in? I think it comes in obviously before surgery, but as you're escalating that pharmacological management, when you're considering opioids, obviously, but also considering sticking the second or third intra-articular knee injection with steroids and anything else, PRPs, hyaluronic acid. Think about GAE. Future direction is it's continuing to evolve, unlike the UAE and the PAEs that my colleagues have spoken of, which are very well established, very well researched. This is ongoing research. It's all emerging data where we're doing multi-centers, everyone's doing their own little studies, and I think it's a watch this space. I think at some point this will be integrated into the osteoarthritis pain management flowchart, and hopefully we can delay surgery. It doesn't preclude patients from having surgery. And I think it's important to educate our colleagues, and especially you guys who are frontline primary healthcare physicians, because this is potentially something we can offer. We've all got the skill set to do it. There's a large volume of patients that need this, so now it's about education. These are my references. Questions?